Welcome to today's webinar with the Accountable Care Learning Collaborative. My name is Scott Hammer, and I'll be moderating today's call on managing behavioral and mental health and accountable care. We're excited about today's presentation and the opportunity to explore this important topic. We're grateful also to have three experts joining us on the call, and we're looking forward to their presentations. Just a few housekeeping items I wanted to cover before we get started. To minimize feedback, please mute your line. If you're dialed in, please use your phone's mute feature. If you are using your computer only, click the microphone icon. If you are using both a phone and a computer, it is best to select the telephone option under audio in the GoToWebinar window, then mute your phone. There should be several opportunities for questions at the end, so please submit them using the questions box of the GoToWebinar window. Jumping to our agenda, the agenda will consist of the following agenda items. First, we'll have John Pullman share some thoughts about the ACLC work groups and the June 8th member meeting. Next, we'll introduce Dr. Dawn Bechtold and Mindy Klowden from the Jefferson Center for Mental Health, who will present on behavioral health integration key to ACOs. After that, we're planning to introduce Dr. Teri Faust from Intermountain Healthcare to share his thoughts on Intermountain's mental health integration program. And then at the end, if we have time, we'll take some questions from the audience. So at that point, I'll turn the time over to John Pullman, Executive Director of the ACLC, to share some thoughts. John?
Hey, great. Thanks, Scott. Thanks, everyone, for letting me jump in here briefly. There's been so much activity in the Accountable Care Learning Collaborative. While we have a few people on the phone, I just wanted to verbally convey a few things. Most of which the activity right now has been going on with our 7 work groups that are identifying the competencies for risk-based bearing entities. We had some in-person meetings in April. Each one of them did. We've had some follow-up calls, some this week and then a few more next week. And right now we are moving forward on identifying the gaps as far as terms that need definition within each of our domains, the structure for our competencies. We're really setting ourselves up to build the work on for the future going forward, and then identifying some of these essential competencies. We have a lot to do before the member meeting on June 8th, and if anyone is not involved in a work group that would like to be, you can email me. You can really, every email you send to Accountable Care LC will come back to us so we can get you engaged. Just speaking to the member meeting on June 8th, we are really hoping we can get at least one representative from member organization there. Work groups will be meeting in 90-minute sessions. There will be an opportunity for anyone to attend 2 of them, so an observer and one you belong to. This will be there will be some plenary sessions as well. We'll give an update and some future plans on the ACLC. We're going to have some representation from CMS, and this is exciting. Patrick Conway, who's the Deputy Administrator for CMS, also runs the CMMI, has appointed one of his deputies, Meg Cox, to be our CMS liaison to help with our interaction and identify the opportunities for us to work going forward. So they will both be there to help bring that connection together. We'll also have a panel on MACRA. There's a lot going on with those regs, identifying the implications, and we'll discuss the operational and policy areas of the MACRA reg. Just a heads up on a couple publications that are coming out regarding to MACRA. Our research team has painstakingly gone through every page of that reg and are just finishing up a summary with some insightful points. You should see that by the end of the week or beginning of next week. We also have a paper on the new CPC Plus program that we're just finishing up, so you can look at that. You can find all these documents on the portal as well as registration for our events. If you don't have access to the portal, again, just let us know on any of these things, and we can help you out. So a lot going on. Scott, we're grateful for you and all these webinars you're putting together, and for our guests that are coming together to present. We know we're hitting on some excellent topics, and so we look forward to this webinar. Thanks, Scott.
Thank you, John. We appreciate your intel and sharing your insights here about the ACLC and what's coming up. In order to set the stage for this topic today, I wanted to share a piece that I read recently in the Concord Monitor News out of Connecticut about the importance of bringing behavioral mental health to the forefront. and I think it'll be appropriate for setting the stage for our discussion today. This is what the piece read. It said, "Mental illness is treated differently than any other illness. It always has been. It remains in the shadows and away from the public square. It is rarely the subject of casual conversation or self-disclosure, and it is invariably an awkward topic when it can't be avoided. People have been taught to hide it whenever possible and to avoid the shame that unfairly comes with it. It is too often perceived as a character flaw or a personal weakness. It is just too uncomfortable to talk about for many of us. And so we usually don't discuss mental suffering with others in the hope that it will not strike us or someone we love. And if it does, we have learned to conceal it, or to at least try and conceal it, which is wrong. Somehow, almost everyone is comfortable talking about heart disease, diabetes, cancer, arthritis, Alzheimer's disease, and even HIV, but none of those conditions come with the inexplicable stigma of mental illness. Given the empirical evidence around us, it's about time that we not only start talking about mental suffering, but learning about it too. Knowledge is our best friend and could help us change the secretive culture surrounding mental illness. We will save and restore lives if we begin to treat mental illness with the respect and humanity it deserves. The great thing is I believe that we have two organizations with us today that are doing exactly that, and so I'm looking forward to their presentations. First, I'd like to introduce our special guests from Jefferson Center for Mental Health, Dr. Dawn Bechtold and Mindy Klowden. Dr. Bechtold is VP, Healthcare and Integration and Mental Director at the Jefferson Center and has been in that position since 2011. He's a practicing psychiatrist. Dr. Bechtold graduated from the University of Colorado School of Medicine at Denver. Following the completion of his training, Dr. Bechtold joined the full-time faculty at the university where he served for 16 years. His clinical appointments at the university included serving as director of the Child and Family Clinic, director of the Children's Psychiatric Day Hospital, and clinical director of the Division of Child and Adolescent Psychiatry, in addition to serving as director of training in child and adolescent psychiatry. He has served on multiple manuscript review panels, such as the International Journal, the Journal of the National Center, and as an NIMH external reviewer. So we're excited to have Dawn with us. Mindy Klowden is the director of the Office of Healthcare Transformation at Jefferson Center, a position she has held since December 2011. Previously, she served as the development director, joining the center in 2005. Ms. Klowden has 24 years of experience in nonprofit management and public policy work, with a particular emphasis on advocating on behalf of and developing programs to support low-income and underserved populations. With that introduction, I'll turn the time over to Mindy and Dawn to address you. Mindy, Dawn?
Scott, thank you very much. Mindy and I are very pleased to be on the webinar today and appreciate the opportunity and the invitation. We'd like to start with just a little bit about Jefferson Center. If you could go on to the next slide. Jefferson Center is a community mental health center in the Metro Denver area. We've been in business since 1958. We're a large center. We have over 700 employees, 13,000 patients active, and around 30,000 people that we serve over the course of a year. We serve 3 counties. Jefferson is a large county immediately adjacent to Denver, the city and county to the west. And then we serve 2 Front Range mountain counties, Gilpin and Clear Creek as well. Should also mention something in introduction about the Colorado Medicaid system because it's relevant to Jefferson Center. In Colorado, the mental health Medicaid is carved out and capitated to behavioral health organizations. And Jefferson Center is also the owner of Foothills Behavioral Health Partners, which is the behavioral health organization that carries the full risk-bearing contract for state contract for 5 counties in the Denver-Boulder area. You know, just one other word about Jefferson. We certainly try to practice according to evidence-based practices as much as we can. Certainly won't go through the long, exhaustive list, but assertive community treatment, supported employment, supported housing, integrated dual disorder treatment, illness management and recovery, and a number of others would be part of the services that we provide at Jefferson. Next slide, please. So this is a slide that just shows the growth that we have experienced. This is between fiscal year 2012 and fiscal year 2015. And I should share with you what our strategic intent at Jefferson Center is, and that is to increase our relevance and value in a rapidly changing environment. And I think this slide really speaks to that. You'll see that you know, the blue is the 2012 and the black is the 2015. Colorado is a Medicaid state, Medicaid expansion state, so not surprisingly, our Medicaid numbers have soared. And the cap is the capitated. Again, this is the mental health carve-out. The next is OBH. These are the self-pay indigent folks. And again, not surprising with Medicaid expansion. Those numbers have gone down considerably. But given our strategic intent of wanting to increase our relevance and value in the environment, you can see that we've certainly worked to do that with the privately insured, with grants and contracts, with Medicare as well. And the last column there, these are folks with in need of behavioral health services, but who don't fall under the carve-out. This would be populations like individuals with cognitive disability, traumatic brain injury, and autism spectrum disorders. So these folks really is a service to them, their families, and the community, because there aren't a lot of services for these folks. We do go ahead and treat, but do this under the fee-for-service arm of Medicaid. Next slide. Learning objectives, you know, what do we hope you all achieve by the end of this presentation? You know, we hope that you've gained an understanding of the drivers that are behind integrated primary care and behavioral health. We hope you understand the essential elements of integration. And again, we're really talking about whole person integrated healthcare and the different levels of integration from low to high. We will give you a number of specific examples of how integration is occurring in our communities. And we'll identify some challenges and ways in which ACOs can play a meaningful role in supporting and promoting integration. Next slide. So this is really looking at a definition of integration. This is from the AHRQ lexicon. This has also been adopted by the Colorado State Innovation Model Initiative. And you'll see when you read this that this really speaks to integration at the level of the practice or the providers. They define it as the care that results from a practice team of primary care and behavioral health clinicians working together with patients and family, using a systematic and cost-effective approach to provide patient-centered care for a defined population. This care may address mental health and substance abuse conditions, health behaviors, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. Two things that people need to keep in mind when they read this, and again, we'll speak more to these as we go on. One is that integrated care does occur across a continuum from very low to fully integrated on the far end. And second is that within practices, really the focus can be different. We tend to think about needing integrated care for folks with prominent behavioral health disorders, and that's certainly true. But it's also true that everyone would benefit from integrated whole person health care. It's not just for individuals with multiple chronic conditions. This is particularly true in pediatric practices, but true for adults as well. Next slide, please. This is another level or another definition that's given to integration. This from the World Health Organization. This really looks at it more at the levels of systems and at population health. Their definition, behavioral health integration, encompasses the management and delivery of health services so that individuals receive a continuum of preventive and restorative mental health and addiction services according to their needs over time and across different levels of the health system. And again, it's really speaking to levels of intervention on one end, prevention and wellness, moving up to early intervention, moving up to subacute and chronic conditions from there, to acute conditions, and ultimately to acute care. But really the value that integration can bring in system-wide or population health management of conditions.
So this is Mindy Klowden. Hello. I'm going to follow up on Don's comments and get a little bit more in depth into why ACOs should be focusing on integration and kind of what the importance of integrating behavioral health and primary care really is in our overall approach to transforming the nation's healthcare delivery system. So this quote here that you see from the Institute of Medicine came from a pretty seminal work that they published in 1996. Mental health and primary care are inseparable, and any attempts to separate the two leads to inferior care. We've really separated the mind from the body, and in reality, mental health and physical health care are inextricably linked. And you know, I think it's pretty telling that this report came out 20 years ago, and here we are as a nation still really trying to figure out how to do this both at the clinical level and the systems level. Next slide, please. So it's not a surprise to anyone on this call, I'm sure, that our nation's healthcare system is severely fragmented, and it's not getting us the results that we need. With providers working in siloed systems, it's complicated for patients. It results in poor communication across provider settings. And we've really been, you know, not prevention focused, or a system that treats the sick rather than really looking at how do we keep people healthy. Next slide. And one of the impacts of this is that it has contributed to the overutilization and inappropriate utilization of the emergency department and hospitalization that could have been preventable. Much of this is really coming out of having mental health and substance abuse so completely separate from primary care. And there have been multiple studies that have demonstrated that people that are described as super utilizers or high utilizers that are inappropriately utilizing the emergency department rather than going to primary care or seeking behavioral health treatment, that mental illness is really prevalent among this population. And so we know that by providing integrated behavioral health and primary care services, we'll be able to help mitigate this overutilization and drive down healthcare costs. Next slide, please. So this comes from the National Comorbidity Study, and what it's showing is that 68% of persons that have serious mental illness have at least one or more chronic health conditions. And this has contributed to a pretty dramatic statistic, which is that people with serious mental illness are dying 25 years younger than their counterparts that don't have mental illness. And it's even more acute when it comes to folks that also have a co-occurring substance abuse disorder. The average age of death for that population with all three conditions is 45. So that's pretty remarkable and really needs our attention as a nation. But this is also showing that 29% of all adults that have chronic medical conditions also have a mental disorder. And, you know, further, one leads to another. The likelihood, for example, of developing major depression increases with each additional comorbid disorder. So when we think about the fact that folks have to go one place for their mental health treatment, another place for their primary care, you know, we're really not looking at how these issues interplay. If someone has comorbid diabetes and depression and they are not looking at how the diabetes is contributing to their depression, and their depression is contributing to their diabetes and making it more difficult for them to develop self-management techniques, we're not going to have the results that we need. Next slide, please. So really what this is all about is that integration is essential to achieving the triple aim. We know that we will have better health outcomes, we will have a better patient experience of care, and we will be able to drive down per capita costs if we're able to further integrate the systems. I think there's a fourth aim as well, which is increased provider satisfaction. When you think about what some folks call the black hole, when a primary care provider refers a patient to a community mental health center or to a behavioral health provider in the community, and they never hear what happens with that patient. There's no communication between the providers, and there's not necessarily any way of kind of following up to see what happened as a result of the patient receiving treatment, or even if they did receive treatment. And this really leads to a lot of provider dissatisfaction. So integration is really essential to helping us move the nation to where we want to be with a transformed healthcare delivery system. Next slide, please. So there have been a number of policy drivers and trends that are moving us further along the lines of integration. And I think that it's important to just kind of understand that the framework that we're operating in is really one where there's increased attention being paid to mental health and to substance abuse for many different reasons, but there's also really increased attention to trying to get past that fragmentation of the delivery system. So some of these policies and trends that are important to understand are the Mental Health Parity and Addiction Act in 2008, which said that if insurance companies or insurance plans are offering coverage for behavioral health, that coverage needs to be provided on par with the physical health benefits. The Affordable Care Act actually took that much further in saying not only if you are providing these coverage for mental health and behavioral health, but that you actually have to provide that coverage because it's part of the 10 essential health benefits. And the Affordable Care Act did other things to promote integration as well. The 2703 health homes, for example, which is a provision within Medicaid that allows for states to seek a state plan amendment and create health homes for persons with one or more chronic condition. That has been taken up in 21 states now and is a formalized way of helping to promote integrated care within the Medicaid system. The NCQA in their PCMH 2014 standards went much further than they ever had before in saying that behavioral health integration is a key component to achieving advanced practice standards. And there have been a number of initiatives that have come out of CMMI that have really promoted integration as well. Next slides, please. So if you look at the financial impact of our fragmented system, what we're finding is that patients with chronic medical and comorbid mental health and substance abuse conditions are costing the system 2 to 3 times more as those without. And this is true across all populations, commercially insured Medicaid and Medicare beneficiaries. And most of that increased cost is attributed not to them receiving behavioral health treatment, but rather on the medical side. And so it's basically saying that if you're not able to address and manage behavioral health conditions, it's going to be that much harder for you to address and manage physical health conditions, and therefore you will end up costing the system more money. Next slide, please. So as I mentioned, this is true not just in the public sector, but also across private health insurance programs. And this slide is just showing that the per member per month costs by medical condition and comorbidity for privately insured populations are increased when there is a comorbidity present. This sort of comparison is useful for gauging the relative potential for savings for each condition if patients were treated in an integrated model. Next slide, please. So Don mentioned that integrated care occurs along a continuum, and we really like this framework that comes out of the SAMHSA-HRSA Center for Integrated Health Solutions. And what it shows is that there is, in fact, a continuum of integration that starts from increasing collaboration across provider systems, moves into being co-located, and then at the highest levels of integration, you're actually practicing from a whole person team-based care approach. And what we're going to do now is share some examples of the work that we have been doing at Jefferson Center along each of these levels in the continuum. if Don didn't mention it before, we are currently co-located in 27 private practices providing behavioral health services, largely to insured populations in those practices. We also work very closely with our federally qualified health center and are integrated within 3 of their practices and 3 of their school-based health centers, and have also brought primary care into 4 of our community mental health center locations. So I'm going to turn this back over to Don, and he'll tell you a little bit more about some of our models.
Thanks, Mindy. First, you see here our care coordination hotspotting model. We were instrumental in the founding of the Jefferson County Hotspotting Alliance. This began several years ago with a small grant that we received called Convenings for Colorado. And really the intent of those grants were to convene your community and to focus together on an area of significance for the members of the community. But we kind of came down to, out of that discussion, this was pre-Medicaid expansion. It was a couple of things. It was the unnecessary overutilization of resources in the emergency departments, and it was also, once Medicaid expansion hit, we would still have some uninsured folks, and how would the community manage those individuals? So we formed this entity that we call the Jefferson County Hotspotting Alliance. We've got the partners, a number of partners. They include Jefferson Center. They include the 2 hospitals in our area, 2 large community hospitals, St. Anthony's, which is in the Centura Health Systems, Lutheran, which is in the Sisters of Charity of Leavenworth system. Includes our federally qualified healthcare center, Metro Community Provider Network, our RICO, Regional Care Collaborative Organization, Colorado Community Health Alliance, Arapahoe House, the substance treatment provider in this area, and the Jefferson County Department of Public Health. And all of the partners contribute either financial resources or in-kind support. This initiative is entirely self-funded. Next slide, please. The goals of the Alliance were to reduce the emergency department utilization for the top 5 to 10% of utilizers in the 2 hospitals that I mentioned. We wanted to identify and reduce the barriers to engagement and utilization of appropriate healthcare resources. We wanted patients to increase their knowledge and skills to self-manage and to follow through with their own healthcare needs. And of course, we wanted to demonstrate a reduction in overall ED costs. And Mindy has already mentioned the triple aim of course, anytime we speak to reducing costs, increasing or improving the patient experience of care and improving the health outcomes of individuals and populations is certainly very much a goal as well. Next slide, please. So the criteria for this were we were enrolling folks for intensive care management who had had 6 or more emergency department visits within the past 12 months, residents of Jefferson County, adults, which for us are folks 18 and above. Exclusions were being pregnant or on dialysis. Another exclusion was a primary substance abuse diagnosis. They needed to have 2 or more chronic conditions. One of those could be a behavioral health condition, but didn't have to be. We also got an initial activation score, which we wanted to follow over time. And in terms of payer, Medicaid has certainly been the largest cohort in this pilot, but we've also followed folks with Medicare, not Advantage plans, self-pay folks, and folks that are dual eligible. You know, I wish I could give you outcomes at this point, but the numbers are still too small for significance. You know, what I can share, though, is that we've seen some early trending in the direction of reducing unnecessary ED utilization. I can also share with you the cost. You know, for the care coordinators, it's about $70,000 a year per hospital. And what you all know about the costs of care in emergency departments, it probably isn't going to require a huge reduction to more than recoup those costs, which of course is important for us to demonstrate. Next slide, please. You know, this just goes over our co-location model. Mindy mentioned that we're in 27 community practices. Again, these are private community practices, primary care, mostly family medicine, one internal medicine, and a number of pediatric practices. We embed a licensed mental health clinician into their practice, and that practice becomes the site of practice for Jefferson Center. Our clinician documents in our own electronic health record. Their documentation triggers the same behind-the-scenes billing that would happen if they delivered the same services in one of our sites. Most of the folks we see are insured, though if the practices are seeing folks with reduced fees or indigent individuals, we don't exclude them as well. And we don't limit the number of services available to folks. Next slide, please. The business model is really very simple. There's no money that changes hand between Jefferson Center and the practice. The practice provides scheduling support and referrals, and Jefferson Center provides a licensed clinician who delivers the services on site, and then we bill fee for service for our clinician's time. We obviously make sure our clinician is on panels for as many of the major health plans as we possibly can. As an entity, Jefferson Center negotiates these separately with each health plans, but we do so as an organization. We don't have to do so provider by provider. Only one of our plans so far is open to health and behavior, 9600 series codes. Only one of our plans pays for case management. For right now, this is a marginally sustainable model. You see a disclaimer there that if anyone is interested in pursuing this further, you certainly need to look at your own payer mixes and your own issues carefully. But in our experience, again, we're certainly not a cash cow, but it's at least marginally sustainable, and moving forward with the integrated whole person healthcare is certainly important and makes it well worth it for us to do so at this time. Next slide. Mindy mentioned embedding folks within our FQ8C, and that's what this slide is about. You know, the providers in this model become a part of the primary care team. They're really practicing what is often called behavioral medicine. And we can go to the next slide because that really speaks to that. But our clinician, even though they're an employee of Jefferson Center, they're really working at the pleasure of the FQ on behalf of the FQ. They document in the chart of the FQ if the patient is open to Jefferson Center as well, and if we have an open release between the two, then our behaviorist will copy and paste the note from the FQ health record into our Jefferson Center health record. You know, I think it's important to mention that one of the reasons we can do this is because mental health Medicaid is capitated in Colorado, and it really allows us the flexibility to invest in these kinds of interventions. So the slide that we're on now really looks at the role of the behaviorists. Again, they provide counseling to folks with chronic medical conditions, things like diabetes, COPD, congestive heart failure, really the full range. They provide screening, assessment, brief therapy, referral. They're a part of the healthcare team. You know, they're helping to educate the medical providers on the healthcare team about behavioral health issues. They're providing curbside consultations to the providers. And when folks within the primary care environment need more intensive, specialized mental health services, the behaviorist is able to facilitate direct linkage to the specialty care behavioral health system. Next slide. This is just kind of a fun slide. The woman on the exam table says, I have metal fillings in my teeth. My refrigerator magnets keep pulling me into the kitchen. That's why I can't lose weight. And probably a number of us can relate to this particular slide. But I think this really addresses nicely the notion of behavioral medicine. Again, it's really not focusing on conventional mental health disorders, but it's focusing on social and behavioral issues that impact people's adherence and treatability for their general health care. Next slide, please. We have several integrated health homes. Mindy mentioned the one on this slide is our most integrated. This has been funded for the past 4 years by a SAMHSA Primary Behavioral Healthcare Integration Grant, and that grant is running out at the end of 2016. Just an aside in regard to that, while for the full 4 years we've really been focused on sustainability, we are aware that a lot of the services that make integrated whole person health care truly integrated still are not sustainable under current payment models. This health home will certainly continue at the conclusion of the grant, but some of the functions probably won't, again, because there simply isn't support for them under current payment models. This is a model with team-based care, and if we could have the next slide, please. The treatment team is both the behavioral health and the medical team. They meet weekly. Includes the primary care provider and nurse and medical assistants, our psychiatrist, nurse, medical assistants, our therapists, the care coordinators. We have health coaches. We have navigation staff. And we have peer specialists on the team as well. We have a paper shared care plan at this point in time because just in terms of interoperability issues, we haven't really been able to make that electronic. But we are successfully exchanging continuity of care documents between Jefferson Center and the FQ at this point in time. And I think, the one point to make with this is that this is an integrated health home that's targeting individuals with multiple chronic conditions, both physical health and behavioral health. And we go into the length of the treatment team and the number of individuals and services. I think it makes the point that this is not an inexpensive level of care. And certainly this isn't the entirety of integrated care. Again, this is on the high end. But when Mindy was reviewing the costs that these folks accrue to the system, again, I think if we can impact and bend that cost curve by investing in this level of intervention, we do have the opportunity of bending the cost curve in the right direction over time. And now back to Mindy.
Thanks, Don. So I'm going to go over some of the challenges and opportunities that we have when we look at how to bring integrated care to scale. I'm going to try to do this quickly because I do want to make sure that we get to hear from Teri. I'm excited to hear from him. Next slide, please. So obviously for this audience, you're all familiar with the fact that we need to move away from being a volume-driven to a value-driven system. But when it comes to thinking about integrated care, I think what's most important to understand is that the time that is required for providers to sit down and consult with each other and to really work as a team to look at the whole person, that the current payment system that is still kind of predominantly utilized across the country is really not able to help facilitate that. So we need to get off of this treadmill. Next slide. So our ACO is ready to embrace integration. It seems like as we look across the country at the development of ACOs that behavioral health has been a little bit of an afterthought. Not all ACOs have kind of a full understanding of behavioral health and that full range of behavioral health, mental health, substance abuse, and the behavioral aspects of physical health conditions. We don't have behavioral health providers adequately represented within ACO governance. Without that voice, we may not really be able to fully utilize behavioral health providers to assist with delivering appropriate services to persons with chronic conditions. We also seem to be in a state where not all ACOs have large enough risk-based contracts to enter into value-based arrangements with behavioral health systems. Next slide. So another challenge that we face really harkens back to the quote that Scott was sharing with us in the beginning about stigma. And if you take a look at these cartoons, it's basically saying that, we still continue to treat behavioral health conditions as moral issues rather than health issues. So have you tried, not having the flu? I don't think it's healthy that you're taking medication every day just to feel normal. Don't you worry it's changing from who you really are? Well, clearly this person is taking an insulin shot, and no one would say this to them, but that's what we hear about people taking antidepressants and other psychopharmaceuticals. Next slide. Cultural differences are challenges as we look at bringing integrated care to scale. We continue to have providers trained separately, paid separately, work in separate electronic health records, and there's also cultural shifts that are really required. For behavioral health providers, many folks go into this work viewing themselves as a human service provider rather than a healthcare provider. And for many medical professionals, we really need to have a shift to seeing themselves as whole person care providers, and where they're recognizing that they have a role to play in looking at things like how does this person's housing situation impact their overall health. Next slide. We have workforce shortages across the country, particularly when it comes to an adequate supply of psychiatrists and psychiatric nurse prescribers. And getting folks that are able and willing to work in rural areas is a challenge. We also have credentialing and licensure requirement issues. So as an example, Medicare is not reimbursing for licensed professional counselors, and so that takes a whole group of people that have significant skills to bring kind of off the table when it comes to reimbursement. Next slide. There's pretty significant challenges when it comes to the exchange of behavioral health information. Don had mentioned lack of interoperability between systems, and of course the electronic health records that behavioral health providers use are quite different from the ones that medical providers use. When it comes to looking at electronic exchange of information, the majority of health information exchanges across the country are not able to support consent-based information. And we're still in a reality where we absolutely need to have signed releases of information until there are changes to confidentiality laws, both state regulations for mental health and 42 CFR Part 2, which says that if you are being treated for a substance use condition, you need to sign a release of information that can be revoked at any point in time and is valid for 1 year. It will continue to be challenging to exchange information utilizing the HIEs. Next slide. Fortunately, here in Colorado and in other parts of the country, some really valuable opportunities that we want to be taking advantage of. I'll just mention there are a number of ACOs with a growing interest in behavioral health. For example, here in Colorado, Centura Health Neighborhoods has decided to use the Community Mental Health Center network as their provider network and are working on contracts with all of us. And Rocky Mountain Health Plans, which is a insurance company within Colorado, has a couple of initiatives that provide primary care capitation and have a strong emphasis on behavioral health integration that includes risk sharing for the community mental health centers. Next slide. The state innovation model, which Colorado is one of the recipients of through CMMI, has a strong focus on integrated care. We're going to, by the end of the grant 2019, we will have 400 private practices and 4 community mental health center-based health homes that have a focus on integration and are receiving alternative payment models and using common clinical quality measures. Next slide. So what's still needed? These are all things that we've alluded to in the presentation. Certainly leadership for change at all levels, where folks are openly talking about behavioral health integration, payment reform methodologies that do support integrated whole person care, workforce development and training, technology and telehealth, and again, the either reform of 42 CFR Part 2 or the ability to achieve health information exchange that allows for granular consent, and of course stigma reduction. Last slide, please. So we found this quote from the Commonwealth Fund and just really thought it encapsulates everything that we've been trying to convey in this webinar. ACOs have the potential to improve access to behavioral health care by integrating it with primary care, including certain incentives and quality measures in ACO contracts may encourage faster integration leading to better health outcomes for patients and reduced healthcare costs overall. So thank you so much, and if there's time to take questions, we'll be happy to after Teri presents.
Thank you very much, Dawn and Mindy, for presenting to us today and sharing your experience from the Jefferson Center. This has been very valuable, and we have actually received a few questions coming into the queue. It's likely we may not get to those questions at the end of this hour, but we can certainly address those questions via email. So keep those questions coming as you think of questions to ask. Right now, I'd like to get to Dr. Teri Faust and introduce him. Dr. Faust is Director of Community Benefit with Intermountain Healthcare, and he's an audiologist and speech-language pathologist. He has led numerous efforts to develop and improve systems for early identification of hearing loss in newborns and early childhood populations for the past 25 years. Dr. Faust has served as an administrator for Intermountain Healthcare's community and school clinics, managing healthcare facilities dedicated to serving low-income, uninsured, and homeless populations. He has developed and directed EHDI programs in Utah, guiding early intervention, oral habilitation programs, and providing direct clinical services at a major children's hospital. He has also been an adjunct faculty member at the University of Utah in communicative disorders. So Teri, I'll turn the time over to you. Thanks so much for joining us.
Thank you for having me, and I appreciate the comments from our previous presentation. They've, I think, will integrate well with my remarks today. Scott, can you go to the next slide? Great, thank you. So let me start off by just sharing some information about Intermountain Healthcare. We're an integrated healthcare system with hospitals, a health plan, and a medical group with clinical programs that influence all three of those. And our mission, can you advance just one click? There is to help people live the healthiest lives possible, of which we really feel our mental health integration program is a key component of. Next slide. Just briefly, just wanted to address population health because mental health integration is becoming part of our overall population health strategy at Intermountain Healthcare. As you can see, the impact traditional healthcare has on shaping population health is small, but we have to look at all these other factors that affect our overall well-being, and so we're trying to look at how we're supporting mental health integration in new ways and in partnering with community partners. Next. Wanted to just give you a little overview of how we try to do things at Intermountain Healthcare. We're really trying to look at success as being improved quality and service with the addition of evidence-based practice plus a systematic approach to evaluation and to measure and to improve. And it's led by our clinical programs, but includes operational, finance, and board governance. So our governing boards are very much aware and involved in all of our clinical programs and protocols, including mental health integration. Let's go to the next one. And again. So let me share what we've heard from our providers and patients prior to mental health integration implementation. Over and over we heard from our providers, if I don't do it, who else will? I'm all they have. I've been forced to treat depression alone. We've heard that over and over. And then from our patients, next, this is the common input, that I was left to figure it out on my own. We never talked about it. He just refilled my meds. So as we've gone forward with mental health integration, next slide. This just looks at our mental health integration overlay with our clinical programs. And what we find is that if you look down on the third line, that we're caring for 2/3 of our patients with complex chronic disease routinely in primary care with our primary care provider and our case manager as needed. We're caring for another 6 with our primary care, our case manager, and mental health as needed. And then for another 6, that remaining 6, with the same team, but with the addition of a mental health integration specialist as a consultant. Next. So I'd like to share some of the results that we've had in almost 2 decades of work by applying mental health integration and trying to apply best practice. Next. So this, and as Mindy and John mentioned, we've got the triple aim, but looking here at the bottom left of the slide, this is our current definition of mental health integration, which is a standardized clinical and operational team relational process that incorporates mental health as a complementary component of well-being and healing. And in routinized clinics, we have a standardized, organized process that's expected and then measured through team participation in designing and improving workflows and tracking our scorecards and dashboard reports. Next. So let's just take a look here at some of our impact and information. If we look at improving physician satisfaction, the yellow is our primary care providers' impressions pre or prior to MHI being implemented in their clinics, and then the blue is primary care providers' impressions post MHI implementation. And as you can see here, the 4 areas of largest improvement, and Scott, could you just click 4 times? There should be 4 red circles come across the bottom. There we go, thank you. And so these 4 areas of largest improvement were the ability to identify mental health needs of patients, the ability to work with patients with mental health needs, and then resources and support to help meet mental health needs was higher, and then the potential for effective mental health integration in the clinic. Then if we go to the next slide, we can look at how our patients were feeling at patient satisfaction. So again, the yellow is pre-MHI implementation, and then the blue is post-implementation. And could we advance 2 clicks? There we go. And so the 2 areas that showed the most improvement were, first of all, the patient's perceived sensitivity of the provider or the physician to their emotional or mental health concerns, and then how well the provider explained things to them in relation to the emotional, to their emotional and mental health concerns. Next. Okay. Now we're really looking at all of these elements here with mental health integration with our primary care and all of our primary care and specialty clinics. We're looking at a holistic approach to patients' health, implementing best practices in all clinical domains. We are striving to have our team members work at the top of their license for what their skill level is. We've established routine protocols and system-based care coordination. And again, in reference back to population health, we're wanting our work to be the foundation for population health management, including financial risk. Next. So this chart looks at how well the team is perceived as being coordinated by phase of mental health integration implementation. So if we look along the bottom, potential is clinics we've identified as they're the next ones we want to integrate, so they're potential sites. The next clinic phase along the bottom is adoption. So these are clinics that have adopted MHI. And the last one is where it's been routinized. So that means all the elements are included and that clinic's been up and going for over 2 years and it's completely routinized. So that's the bottom axis. Then over on the side we're looking at the perceived coordination team interactions. So how well the team is coordinated around that particular, around those cases. So this, as you can see there, in the light gray are patient responses, the dark gray staff responses, and you can see those significant increases as a clinic moves from potential through adoption through routinized. Okay, next slide. So just moving forward, we are using the term team-based care now, which was referenced earlier, as the combination of personalized primary care and mental health integration. And so we're just referring to that combination as team-based care. Next slide. Okay, just wanted to give you a snapshot of our workflow. here, and this is our mental health integration treatment cascade. And so patients or cases are identified through shared decision making with our primary care providers and the patient. They're given a mental health integration packet, and then based on the outcome and the scoring on those packets, they'll fall into one of these three categories based on the complexity. Those with mild complexity are cared for through with their primary care provider and care manager, and those that are moderately complex, there's more of a collaborative MHI team approach, and then clear up through the mental health team high complexity, where we bring all of our resources into bear to support that patient and their family. Next. So in our clinics where mental health integration has become a normalized and routine part of our care, their outcomes are better due to multiple connected team touches. So in their words, we, including the patient as an active member of the team, we were on the same page and we talked to each other. Next. So looking at our outcomes, our key research aim, we really set out to investigate this question. Do clinics with high-performing team-based care provide greater value compared to other clinics operating under a more traditional patient management approach, and as measured by quality and clinical outcomes, cost, utilization, patient and family service, and staff outcomes? Next. Okay, so the culture of team-based care at Intermountain has been steadily growing for 10 years with more concentrated investment and growth in the last few years. This slide here shows the progression of team-based care in our system. And so the lightest color is usual care practices that are practices without team-based care. The light blue is team-based care. And then the dark blue are those highly routinized. They've been doing it 2 years or longer and are meeting all of the benchmarks to say that they're a fully MHI routinized clinic. And so you can see the growth that's happened there, how we've gone from 13 team-based care practices up to 53 in over a 10-year period. Next. Okay, so looking at outcomes here, this is looking at what we call our 5-part bundle, but it was looking at our medical groups, clinical goals and processes as well. And so we've looked at annual visits of the primary care provider, those that have had a PHQ-9 screening, adherence to the diabetes bundle, hypertension in control, and advanced directives. And so you can see here that outcome improved, and this is due to both changes in clinical delivery and consistency in data capture, and it's important to keep that element in mind too. So you can see the change for those clinics with team-based care. Next. Okay, and then looking here, this looks at our utilization of healthcare services. So for those clinics that were completely routinized with mental health integration, we saw that our emergency visits were down 11%, hospital admits down 22%, what were classified as avoidable visits and admissions down 21%, and then an increase in our primary care provider visits 4%, an increase in 13% of our urgent care visits, and then radiology testing was down 11%. Okay, next. And so overall, our research and our information back is showing that we've had, for an investment of $22 per member per year, we've been able to decrease medical expenses by $115 per member per year. And next slide. Just always like to conclude by ensuring that that we know that it's more than just a program, but really to the lives that it touches. And we've heard this by several patients, but this is one of the first and one of the clinics I implemented in, where they came and they said, my doctor was the first person to treat me as a whole person. And that's what we're really trying to affect. And I apologize for going through those so quickly, but hopefully we got through most of that information in our time period, and we'd be happy to share additional information by request. Thank you.
Teri, thank you so much. Very valuable in understanding what Intermountain is doing with mental health integration, and interesting to see the two different systems, Jefferson Center and Intermountain, and the similarities that they have as they approach mental health integration and how they're managing behavioral and mental health. As Teri mentioned, and Dawn and Mindy, we're at the hour and we won't be able to take questions, but if you send those questions via email, here are contacts for Mindy, Dawn, and Teri. But if you have questions for us, you can send them to members@accountablecarelc.org. We'll get those questions, and then we can send those off to Teri and to Mindy and Dawn as appropriate. And if you're looking into building or developing your mental health integration program, please let us know, and we can certainly, as Teri mentioned, have you talk to either Teri, Dawn, or Mindy about what you're doing, and I'm sure they could give some help or advisement. So thank you to Dawn, Mindy, and Teri for their insights and perspectives today, and an audio recording of this conference call will be made available, and we will be including that in our weekly news summary. The next webinar will be on June 30th on the topic Strategies to Integrate Pharmaceuticals and Accountable Care. Our special guest will be Kimberly Westrich from the National Pharmaceutical Council and Amanda Brummel from Fairview Health. Thank you for joining us, and we hope that you found this presentation valuable. Have a great day.